Uh, good af good afternoon, everyone, and thank you for joining us today. My name is Barry Stein, and I'm the President and CEO of Colorectal Cancer Canada. I'll be moderating today's panel discussion on establishing early onset cancer clinics, colorectal cancer clinics, and this topic is extremely personal for me, having been diagnosed with metastatic colon cancer to my liver and lungs at the age of 41 in 1995. Like many early onset patients, I experienced firsthand how existing cancer care pathways weren't then, and even not now, designed with younger adults in mind. My personal experience, combined with the work that we do nationally and internationally at Colorectal Cancer Canada in our early onset program called Never Too Young, is what ultimately led to today's conversation. We're also here because early onset colorectal cancer is no longer an outlier. It's a growing and urgent reality. And while cancer mortality has declined for most malignancies in people under 50, colorectal cancer is the exception. Younger patients are frequently diagnosed late, present with more advanced disease, and face complex challenges related to fertility, genetics, psychosocial support, interruption of their careers, and long-term survivorship. Traditional care models often struggle to meet these needs. Increasingly, clinicians, health systems, together with these clinicians, are recognizing early onset colorectal cancer requires intentional, coordinated, multidisciplinary programs, not just good intentions within the existing structures. This webinar builds directly on a recent multi-institutional paper that several of us co-authored, which examined how dedicated early onset colorectal cancer clinics were established and how they operate across different hospitals. A link to the paper may be found in the chat, as well as the full biographies of today's panelists. I'd like to express my gratitude to our other co-authors who could not be with us today for all of their work on the article and their dedication to early onset colorectal cancer research, including Dr. Kim Yang, Dr. Petra Wildgoose, Dr. Andrea Surchik, Dr. Aparna Parikh, and Uditi Reddy. The goal of that work and today's discussion is to move beyond awareness and towards implementation. So I'm honored to be joined today by three exceptional leaders, hopefully. So far, we have two. One, Cathy Yang, may not be able to make it today because of weather, apparently, in Tennessee and power outages, but hopefully she'll be able to join during the course of this webinar. Dr. Cathy Yang, hopefully, as I said, will join, is a medical oncologist at Vanderbilt-Ingram Cancer Center and director of the Young Adult Cancer Program at Vanderbilt-Ingram Cancer Centers in Nashville, Tennessee. She brings extensive experience in clinical trials, program development, and national leadership in gastrointestinal oncology. And I'm pleased to say as well that we sit together in an international early onset colorectal cancer research organized by our friends at Fight Colorectal Cancer in the United States. Dr. Nancy Yu, who is with us already today, is a surgical oncologist and whose work focuses on early onset colorectal cancer and hereditary cancer syndromes at MD Anderson in Houston, Texas, and is the medical director of the Familial High-Risk Gastrointestinal Cancer Clinic and the director of the Young-Onset Colorectal Cancer Program. And she plays a key role in integrating genetics, surgery, oncology, and survivorship into coordinated cancer pathways. Dr. David Liska is chair of colorectal surgery at Cleveland Clinic in Cleveland, Ohio, and is the director of the Cleveland Clinic Center for Young-Onset Colorectal Cancer. He serves as the director of the Sanford R. Weiss MD Center for Hereditary Colorectal Neoplasia and the Cleveland Clinic DiBartolo Center for Young-Onset Colorectal Cancer. Together, this panel represents surgery, medical oncology, genetics research, survivorship, and systems-level leadership, the core components of the effective early onset colorectal cancer care. I'll just take a moment to walk through today's agenda so that you know what to expect over the next 90 minutes. And we'll begin by discussing, of course, why early onset centers are necessary and why traditional pathways fall short for younger patients. We'll then move into how early onset centers were established, including decision-making, leadership engagement, and implementation within complex health systems. And then we'll focus on what early onset centers deliver in practice, including clinical services, multidisciplinary coordination, genetic, psychosocial care, survivorship, and research integration. Our objective today is not to present a single blueprint, but to share real-world lessons and transferable strategies that can be adapted in other institutions. And with that, I'll move us into a few quick housekeeping items, and then we'll begin our first discussion segment. The webinar will be recorded and will be available for early next week to watch and reshare. The last 15 to 20 minutes will be dedicated to answering your questions, and you can add questions by clicking on the Q&A function at the bottom of your Zoom screen at any time. If you have a question for a specific panelist, please indicate their name in the questions. And we'll try to get to all the questions, but if time runs out, we'll get back to you post-conference. So with that, let's get going. So this is a question which I'm just going to throw out in order to Dr. Yu and Liska in that order. Let me ask you, why did you feel it was important to start an early onset center at your center? And we'll start with Nancy Yu.
Sure. Thank you so much for having us. And I think it's superb that this webinar is taking place. I think what really drove me and my interest in onset and building a program is it was so obvious when we see younger patients that they're different, that their needs are different, their struggles are different, and their cancer journeys are different. And I think, many of the existing infrastructures in place are not proactive enough for these young patients for whom I think cancer is not even in their vocabulary, and what they need as they go through cancer may not be known or obvious to them. And so I think it was clear to me that a more proactive and organized and coordinated approach is needed to really help them in their journey.
David, why did you feel it was important?
Yeah, thanks. No, I think exactly what Nancy said, but also what you already said in your introduction, right? You going through your own cancer journey, and I think it's something that all our young patients go through, is realizing that the infrastructure, the services that are set up currently, are not sufficient to address the specific needs that are more applicable to young people with a diagnosis of cancer, and especially young people with a diagnosis of colorectal cancer. So it is that for the most part, but it's also, even what I noticed, even in my own practice, and over the last 10 years, we've been noticing more and more young people with a diagnosis of colorectal cancer showing up. And even for someone like myself, who's extremely passionate about providing the best possible treatment to young people with cancer, to all people with cancer, but also a more tailored treatment to young people, I've noticed that in the course of a very busy practice, be it as a surgeon, as an oncologist, whatever it may be, you sometimes forget certain things that are important for that specific patient in front of you. And the only way to make sure that all items get checked on, that all items get addressed, that the patient really receives personalized but also comprehensive care, is to have a system in place, to have an infrastructure in place, to have a center where all specialists can come together to address all these different aspects. And I think that's why it's so important to have a center. It's not enough to only have a physician or several physicians who are passionate and interested and capable, but you really need to have the whole infrastructure and all the wraparound services around as well.
So it's that coordinated approach, it sounds like, that's a little bit different in having this type of center. I was trying to think about the different ways that, the existing pathways outside of a coordinated center like that fail the patient. And Doctor, in your center, if a patient comes in, they're going to get more of a comprehensive evaluation, perhaps be triaged in different ways. But before you had the center, how did you view, how the system was failing your patients?
Yeah,
And
I
what,
think, dovetailing on what Dr. Liska just said, it's, I work in a cancer center, and so it's not like the support services are not present. But the link between the patient and the support services in the usual care pathway relied on the patient. The patient must voice the need, and then the clinicians must respond. And so I think by developing a more dedicated center and dedicated program, all of that happens a little bit more, definitely, a little bit more proactively, a little bit more automatically, and I think reduces the variation in care. We've looked at our experience with our care coordinator now, whose major role is to do a needs assessment proactively and then proactively connect the patient to consult services. But the patients who she's able to connect with and really touch on end up being connected to more support services than those that she's not able to connect with. So I think, having a system reduces the variation in care and hopefully overall brings a better experience for the patients.
I was thinking about it, and I was 40 or just turning 41 at the time. And but many of the patients today are between 28 and 39 years old. One of the fastest growing segments of patients with colon and mostly rectal cancer at those ages, it seems. It's their first experience with the healthcare system. So you're not familiar with who to see, what to ask for, or even how to navigate the system as a whole. So I think that really underscores what both of you were saying in terms of having this coordinated approach to give comfort and really guidance to help navigate the system as a whole. I could certainly relate to that in the early days in 1995, and when there was really just one treatment and very little surgery, and a lot of different no diagnostics like we have today, and certainly no molecular profiling. So at that particular time, it was really much easier, and I was 40 and a lawyer at the time, so I was able to navigate a little bit on my own. But for the average person, even at that time, it was extremely, difficult. So I'm really happy that Dr. Angus joined. You've had your intro done already. Apologies for that. I'm not, you're still on mute as well, which is fine. So welcome. And, my first question was, why an early onset center? So as you settle in, think about, going back to when you decided to set up an early onset colorectal center. Dr. Ang, I'm going to pose this question to you. Why did you think it was so important to start your center at Vanderbilt?
I apologize for being late. I'm sorry. Just a little disoriented. It's been a bit tough given the weather situation in Nashville lately, so I apologize. So the reason I started the program, and basically it's been something I've been wanting to initiate for probably now 2 decades. It's really you see these patients in your clinic that obviously they have different needs than your average age patient. And you want to be able to assist them as much as possible because of the additional stress that is caused not only by being very young at their diagnosis, but also facing other challenges in regards to job security, financial security, fertility planning, family planning. There was really nothing that was available at the time when you were seeing more and more patients. There was nothing really available at that time where I could provide significant assistance to these patients without having to go to multiple providers individually. And this allows a much more team approach to the patient. And this way, the patient is aware of what services are available to them at all times. So they can reach out whenever they need to throughout their treatment. Usually not always the first visit, but they know you're available.
Right. So that we were discussing that coordinated approach and really structured approach to help guide young people through the system that they're often unfamiliar with and confronted with some obviously life-threatening disease and impact to deal with things depending on their age that they may have never experienced before. So totally relate to that. And as I said, I myself was a little bit more experienced, not in the healthcare system, but just in the question of being able to advocate for myself. And this made a difference for me. And I'm thinking about how the work that all of you do. I know that advocacy is a big part of it. In terms of your advocacy, what was the turning point that brought you from, thinking about the concept and the need for the concept to advocate for these type of changes in your institutions? And I know that wasn't an easy journey. So we'll start with Dr. Yu, and we'll go to David and then to Cathy as well.
I think I've been in practice for 15 years, and Cathy knows this, that the conversation has been happening for 15 years, and as you allude to, things bubble up to a level that reaches a turning point. And I think we're, just as a larger conversation in the community, finally this is now front and center in the public media and in people's minds. And so all of that helps, I think, toward moving an institution to a turning point. But I think for me, the kind of when things became real was when the passion for it went beyond myself, that there was a critical mass now, a critical mass of multidisciplinary providers, whether it's, the partner in medical oncology, the partner in radiation oncology, and maybe the partner in the young AYA program. But I think it's just gathering up enough of a critical mass that you're able to make some actual action forward. At least that's what it was for me.
And David, did you meet any opposition in your center in terms of getting it going? I'm sure from a financial point of view, questions were asked in all of your institutions. Why are you so special that you need a dedicated center for early onset versus other cancers?
Right. No, I think that's a great point. And I think what Nancy said is absolutely right. It wasn't some sort of like critical aha moment. It's something that's kind of been brewing for many, many years. And, us sitting around the tumor board and just seeing more and more young people getting presented with very advanced disease, it just, there was a critical mass for sure to say we need to do something, to better understand the disease, better understand why this is happening, better, treat these patients better. And so having that critical mass of a multidisciplinary team that is extremely passionate about, not only providing the best care, but also understanding better so that we can, advance the field as a whole. And I think that was all critical in getting a center such as ours off. Were there problems? There wasn't necessarily opposition. Everybody, you tell them about it and they all say, yeah, for sure. This sounds like a great idea. No matter who you ask, the financial aspect, that's kind of a separate thing, right? People, even the people who are in charge of the finances will tell you, yeah, this sounds like a great idea. The next question is, so where are you going to get the money from to do it, right? So I don't think anybody would ever oppose, the idea of serving young people with cancer. That's just the nature of the disease. It's something that anyone can immediately realize that this is something important. In terms of the financial bit, we were fortunate here at the Cleveland Clinic, and we already had a center in place that was dedicated to patients with hereditary colorectal cancer conditions. And this is a center that was founded back in 1979, and we're extremely fortunate to be taking care of these very, subspecialized patients that many of them happen to be young, right? Because it's hereditary colorectal cancers, most of them are young people when they get diagnosed. And so it wasn't a dedicated center to young people with colorectal cancer, but I was able to lean a little bit on the resources and infrastructure of that center when we just started. That was, for the very first several months. Now, once you kind of then show that there really is a need there and a benefit to having such specialized care for young people with cancer, I think then it became easier to argue for the financial aspect. And then we were very fortunate to partner with philanthropic donors. In our case, Eddie the Bartolo family was sort of a critical donor to make it possible from a financial standpoint.
Right. It's always those key donors that and the foundations that actually make innovation happen. And I do think that this is an innovation. It's not just it is an unmet need for sure, but it's also an innovation at the same time. So, Dr. and Cathy, was there a turning point for you when you decided to do it? And if so, what were the unmet needs that you felt, weren't being covered at that time? We talked about the need for a coordinated approach and help to navigate and so forth. But were there other sort of needs that made you decide that it was important to open up one for colorectal specifically, or how were you approached with respect to that?
So our program here is not specific to colorectal cancer. It's for all early onset patients that are less than 50 years of age. So I wanted to clarify that. The turning point, honestly, this is something I've been wanting for, literally two decades of my life, when I was seeing such a large number of young adults come through my clinic. As a medical oncologist, as you know, we take care of these patients. Since the majority of patients present with stage 4 disease, we take care of these patients throughout their entire lifespan. And if they are incurable, you learn a lot about the patients, their family members, all the struggles that they go through with their diagnosis. And I think it's that connection with the patient that really demonstrated to me how important it was to tend to their needs and try to help them throughout, unfortunately, throughout their diagnosis as much as possible. David brought up a very important point. Financially, it's very challenging. When I came here to Vanderbilt, there was not a program, as you mentioned. We started the program here based upon that was part of, in honesty, and part of my job recruitment was to help create the program that I had been seeking. And initially, there was no funding that was associated with initiating the startup of the program. But when I sent an email out to see who was interested, the response was incredible. And there were 20, 30 people in the room that all wanted to participate in this effort. And basically trying to find philanthropic donors, obtain small grants, that's really been the impetus to keep the program up and running, and salary support, et cetera, because obviously you need coordinators and you need consent and you need individuals that are vested. So, I think it's just really important for people to emphasize that I think people forget that in academic medicine, we still need financial support, because as David mentioned, it's not the people, an early onset program, it's not the highest in priority for any major medical center, because there's obviously a lot of other priorities as well. And so financially, you just have to keep on pushing and trying to get support for the program. And it's really important that people remember during philanthropic efforts that it's great that they want to donate money to children's cancer efforts as well, but our young adults need support as well, and that's it's a critical component.
Oh, absolutely. I couldn't agree more. And certainly the demand for funding, and particularly in research as well, is challenging, let alone especially now, let alone the sustainable support to keep these type of clinics going. There's no question about that. So I mentioned in the introduction that we do sit on a research group together with our friends that fight colorectal cancer in the U.S. And I was thinking about it. We know, that between 28 and 39 years old, we see a lot of rectal cancer patients. For whatever reason, we know that there's a genetic component and hereditary components that David brought up. But I'm wondering, from all of your experience, what you view as the most urgent need, whether it's from a research point of view or a health systems point of view, to address this, I would say, practically an epidemic of young people, young adults being diagnosed with colorectal cancer. So we'll start with you since we're on the research group together, and it's a question that we have to answer. What do you think is the most pressing research need?
I think right now we don't know the exact etiology, right? I think that that's very, very important. There's no specific molecular mutation that we've identified for our non-hereditary colorectal cancer patient population. And so what can we do? I think the most important thing we can do is continue to educate about awareness and promote, obviously, getting screened when patients are having symptoms, but their primary care physician needs to be aware of the symptoms, the family practitioner, the pediatrician. We need to continue to educate our non-oncology colleagues about what the signs and symptoms are so that young patient can get diagnosed earlier rather than later. That's the thing that we can do immediately. Obviously, research will continue, and there's so many other aspects that are being investigated in regards to why this is happening. But once again, there's no specific etiology that we've identified at this time for the non-inherited forms of colorectal cancer. It appears to be multifactorial, and research will continue. But for immediate impact, I think we really need to continue to encourage screening, recognize the symptoms, and promote education and awareness.
So certainly awareness, recognizing the signs and symptoms, and to be able to address patients as early as possible, know your family history and so forth. This is an educational aspect, both for the population at large, of course, even for our primary care physicians to recognize patients early so that they can address these needs. So as a medical oncologist, you see this, and I think that you're on those lines. When people come to Nancy and to David, they usually, as surgeons, they already have the disease, rectal or colon, whatever the case be. And we have seen some interesting work by Andrea Serchek, who's also one of the co-authors, in terms of neoadjuvant treatment. So all this research and coming together of the
Neoadjuvant treatment in the MSI high setting,
and yes,
not in your MSI stable, more common patient
at least for
population.
today, and we're starting to see some trials in the adjuvant setting as well. But in the neoadjuvant setting for MSI high patients, we hope to see soon. We're seeing some trials for the microsatellite stable patients starting, but it's early days, actually early days for both, I would say. But we are starting to see different approaches, whether it's through medical oncology or surgical or radiation, for that matter. So. Nancy and Dave, from your perspective, starting with Nancy, how do you see the importance, number one, of your clinic and your role as a surgeon in addressing those unmet needs?
Yeah, absolutely. So I really like this definition of cancer survivor as that it's the survivorship starts on the day that they're diagnosed. So I personally think that as the number of young cancer patients increase, the major task is how do we optimize survivorship? And a part of that is how do you personalize treatment in a way that you maximize the benefit versus risk ratio so that they really get the impact of the treatment while minimizing toxicity. So as a surgeon, I play a role in figuring out what is the regimen of neoadjuvant therapy for a rectal cancer patient and what type of surgery to do. Everyone that's diagnosed with rectal cancer walk in the office thinking they're going to live with a colostomy forever, and they're super afraid. And, we live in this super exciting era for rectal cancer now where there are so many options and so many treatment pathways. And I think, at least for me, it's just, this is not one size that fits all anymore. And how do you, right, look at the patient, understand their personal preferences and their priorities, and look at their tumor and figure out what therapy works for that tumor, what is the risk for that tumor, and then coming up with a regimen that actually fits, that is best for that person.
Right. And
Can I
there's
emphasize that the regimen must be multidisciplinary with the medical
Yeah.
oncologist choosing the regimen?
Yeah,
right.
right. It just takes a whole team now, and it really right. I mean, to your point, right? Like, it's not like I can be like, no, I'm signing up for surgery tomorrow. That is not going to be the best interest for the patient.
And that's exactly what David was speaking to before, that multidisciplinary team that's so important is to, why, how do we meet the needs of the patient and why it is so important. And, it's funny that you talked about the possibility of an ostomy. I would say that that's probably one of the first things the patients say to us, oh my God, how am I going to do this if I'm going to have an ostomy? Cathy, I see you have your hand up.
Yeah,
Go
I
ahead.
wanted going along with the multidisciplinary team, which is critically important, but we also have to keep in mind there are some individuals that don't have access to a multidisciplinary team at their institution or place of practice. And especially because we know that there's a rising incidence as well in our American Indian um, patient population as well. And so access is an issue for a lot of individuals. And so I think that's really, really important to keep in mind. That still remains a huge challenge for some of our practitioners, and hopefully there's can find other resources and identify other colleagues that they can at least partner with virtually to review cases. I would hope moving forward. I hope that people understand, or our young patients should understand they should get a second opinion if they don't feel comfortable with just a single opinion, if it's not been discussed at a multidisciplinary effort, with the multidisciplinary effort.
I think that's a really important point. So those centers that are thinking about starting a clinic, you don't necessarily have to have all the resources within one institution. You could farm out, so to speak, but so long as you have those contact points or that network, that community of practice, I think that's essential. And I think, and Nancy, in the past, you mentioned to me that even at MD Anderson at one point, I don't know if they do now, they didn't have a fertility clinic, but having that link and that community of practice was essential. And David, what did you experience in that? Did Cleveland Clinic have all the resources that you needed when you started?
Yeah, no, it's so like I think like the others have mentioned, it was definitely apparent that we have almost all resources at a place like the Cleveland Clinic. We had almost all the resources here, but getting them all connected and getting them all sort of um, available to the patient, when they present and easy for the patient to access, that was the critical component that was missing. Now, it wasn't, there were certain components that we currently provide to our patients where they could have been available, but we didn't even know that they would be beneficial. And that's something that we've learned a lot of times from our patients. We have a patient advisory board as an important part of our Young-Onset Center, where we asked them, during your what was it, during your treatment or after, now in your survivorship phase, what was the most frustrating in terms of things that we weren't providing at the time that you think would have been beneficial, or that we ended up providing but should have provided earlier. And we've learned from our patients over the years certain things that we didn't offer at the very beginning, and now we do. And that's, again, thanks to our patients and thanks to our coordinators. And I see that some of them are on this call right now and on the webinar, which is great. From then talking to the patients and understanding the patients and being with the patients sort of on a regular basis and knowing which of the different things that we offer our patients are most impactful, and then making sure if it's not already in place that we put it in place. So it's definitely still a learning period for us, and we will continue learning from our patients and from all our caregivers in terms of what is important and when it's important. I think that's a critical component that we didn't realize, that certain things that you think might be great, they might not be great at the time. So it's a long journey, starting from the diagnosis to the survivorship phase, and there are different needs at different time points.
It's very, I think that's really important because, some of our work in patient preference studies that we do together with the Health Technology Assessment International and the University of Calgary as well, it really indicates that patient preferences are fluid. And what might be important at one point in your life or one point in your treatment may vary as you go through time, number one, and of course, the different types of treatment that you receive, and of course, influenced by your family and your friends as well, heavily influenced by that. And that's really an interesting, point when we start to think about clinical trials as well, and encouraging patients to play in clinical trials. But you mentioned, David, that there was, some of the resources that that you had, but you didn't think that were appropriate, or you didn't think of putting into the program. Can you give an example of something like that?
Sure, sure. So one example that comes to mind, a nutritionists to counsel patients. Um, we obviously we do major surgeries on these patients that affect your GI tract. Be it with a temporary stoma, a permanent stoma, no stoma, or even without surgery. Now that we're doing non-operative management with chemoradiation, it affects the GI tract. The treatments we do affect the GI tract, and that will affect um, the type of diet that a patient might tolerate best at a certain time point. So having an early on checkpoint with a nutritionist to talk about, diet that may be, specific at the given time point is extremely helpful. But even in patients that not necessarily have any changes to the GI tract, we found that, patients are very interested in learning more about what is the right nutrition, especially once you're hit with a diagnosis of colorectal cancer. And, one of the early things you'll read is that, diet has an impact on the risk. Diet is one of the risk factors when we talk about colorectal cancer. So they want to know what is the best diet I should be having to reduce my risk or to reduce my risk going forward. Family members, what should we be eating? So having nutrition be a integral part of our center, and that was something we didn't realize at the beginning, and then we noticed later on. Another example I think that came up more recently, when we learned again from our patients, what they really were interested in was being able to talk to peers, to other patients who've gone through similar treatments, similar diagnoses, similar setbacks, and how powerful that can be. And we now have a psychotherapy group that's moderated by a psychologist that's part of our center, part of our department, where they do some CBT, but also are talking to their peers, to other patients. And we learned just recently, over the last year, we've had two cohorts. We have one rolling out now. And again, all that made possible by our amazing coordinators to get these patients plugged in. But that's something that I didn't realize was going to be something important when we started our center. And now we have these, psychotherapy groups with peer support.
I have to say that nutrition was, high on what I asked for at the very beginning, wondering, could I make my cancer go away because of what I eat? And of course that wasn't possible. But today we look at, we have an ongoing study right now in Canada, the William Osler in Ontario, on assessing people at the very beginning, or determining whether they're being assessed for malnutrition, even coming in and addressing those nutritional needs. And there is, let's just say, an under use of nutritionists, and there's not enough nutritionists and or dietitians around who could help in that regard. So having them together in a center like this is I would say, of fundamental importance, or at least having a link, through a community of practice to that, and making those assessments early on. We know that later on we're dealing with things in terms of treatment, in terms of cachexia and things of that nature, but that's a little bit, later on, usually. From a psychosocial point of view, I think we've seen this, over a long period of time, and I still think that those needs are not adequately addressed in most centers. It's extremely difficult to get in touch with, at least in Canada, with an informed psychologist or someone practicing in the area. So again, having those needs met in your centers is really fundamental. And before we go ahead, Kathy.
Just tagging onto that, As you mentioned, some centers may not have that type of subspecialty, and we are very fortunate. We have started a psych onc program a few years ago, but keep in mind there are organizations that you can partner with, such as Gilda's Club does counseling for free, and that's available nationwide in the United States and most of the cities. But I'm sure there's other programs as well that are similar that you can partner with in regards to psychological assistance, because obviously it's a very, very challenging time for these patients. And I highly encourage therapy for many of our patients. I think it makes a huge difference.
Funny you should say that. When I first started my treatment, I was in New York. I had to leave Canada for some of my treatment for hepatic arterial infusion and so forth in New York. And I did meet up with Gilda's Club and the founders of Gilda's Club, not Gilda, she passed away at the time, but I did meet her psychotherapist, Joanna Bull, at that time. And we ended up starting Gilda's Club in Canada going forward. So I did get to meet some of her family members and was inspired by that. And now, of course, the cancer support community has taken that over, that challenge, and doing a great job of it. So, Nancy, at MD Anderson, in terms of psychosocial support, how does that work?
Yeah, so I think bottom line is we rely a lot on community services as well. We have a My Cancer Connect program, which tries to do a matching of patients to their bank of trained volunteers who are able to do some talking. It's not formal therapy though. When it comes to formal therapy, we actually don't have a lot of in-house therapists. We have psychiatrists, who will do consultations on patients on active cancer therapy, but we don't really have the body of providers that's able to build a long-term relationship with the patient as they go through their cancer journey. And so we do rely a lot on community resources. So I think, again, right, like I think something that Dr. Liska just talked about, having a dedicated person in the program that's able to provide that would be extremely helpful. Again, in a way that's proactive for the patient and not rely on the patients to dig out resources themselves.
Yeah, we've talked quite a bit about why these centers are important and the reasons for it and meeting the needs of the patient. But we do have with us today some physicians who are looking to start centers of their own. And so where to begin? Who do you speak to? And what are the first steps that you took? And we'll start with you, Nancy, and we'll go in reverse order this time. Who was involved in the decision making to establish the program, and how did you go from recognizing that there was a need or a problem to actually implementing that change?
Yeah, it's to summarize, it's probably just navigating the system. So I think, I think my first step was to gather partners, identify, just a small core group, 3 people maybe. I, had a medical oncology partner, a radiation oncology partner, and we sort of just sat down and sketched out what the program might look like. So because step 2 is just kind of making a proposal, right? You have to make a proposal of the plan. And then I think the next step is to building the business pay, kind of converting a program proposal to a business portfolio. And in that step, going from step 2 to 3 will require identifying really the partners in the other services, right? So we needed to have individual meetings with individual services that we're interested in bringing in. So the social worker group, the genetic counselor group, the nutritionist group, or the pain services, and then our child life support group. And so that probably takes the longest time to present your vision to each of those groups. And then basically the ask is, do you have part of an FTE that you can dedicate to this? Or do you have a point person in your group that we can count on as our point person for this group of needs? So once that's there, then I think it makes it a little bit easier to move to a business portfolio model because you have more, you have all the names and the structure mapped out. And then that can also translate to, right, what is the financial need in terms of FTE needs and so forth. And then I think step four is, as that's probably institutional dependent, right? How do you socialize and then get approval for a business portfolio proposal?
That's great. And just a reminder to our listeners, we have in the chat, it should be in the chat, I can't see it, the article with some of the key points that you just outlined as well. So that article is available and it's in the chat. And feel free, if you have some questions, to put that in the Q&A afterwards. So David, how did you do it? How did you get your allies together and strategize in order to bring this program together? I imagine the fundraiser or the philanthropist had something to do with it as well.
Yeah, for sure. No, and I think Nancy's absolutely right. It takes first a small core group of passionate people who are interested in it, then identifying the point people in each discipline that you might involve. Each discipline, each service line, be it social workers, be it nutrition people, psycho-oncologists, etc. So finding the right people, and then what Nancy also, we did the same thing. We went through sort of like an algorithm. Let's say a patient, how do you identify a patient? Once you have identified a patient, what is kind of the care path that this patient that you would ideally have the patient go through? To put it all together, though, the critical part is what Nancy said, is that person who has bandwidth or FTE, right? Having a person that is the coordinator to put it all together, and you can give that person different names, coordinator, navigator. It doesn't really matter what the name of the position is. It's more important what that person does, and that's really a patient-facing person who has the knowledge of what a young person with colorectal cancer, what are the different steps they should go through at the time of diagnosis, during the treatment, in the survivorship phase, sort of knowing what the steps are that they should have access to, and then making sure that that patient gets connected with these different services, different disciplines at the right time, based on what the patient is interested in. And I think what you said at the very beginning, how young people, besides cancer, especially rectal cancer, being extremely complicated in terms of treatment, right? Navigating rectal cancer, even for somebody who understands rectal cancer, is extremely complicated. For a young person who has had zero sort of exposure to what the health system really is, and it's extremely daunting. Then on top of it, you have a young person who hasn't been exposed to the health system, and then gets exposed to it, but at the same time feels that isolation of being the only person in that age group that is navigating it. All that is extremely daunting, and then having that coordinator that says, hey, we deal with people like you on a daily basis, multiple patients, we'll walk you through it. First of all, it normalizes things to some extent, as much as you could normalize such a diagnosis, right? But saying they're not alone in the fact that there are other people going through it, and not only are other people going through it, but we have the resources to make sure that we will provide the best possible care. So having that coordinator, I think that is really the breaking point when you're trying to build a center, having the coordinator that gets all these different services together and make sure that the patients has access to them. I think once you have that person that is, that your institution will support or philanthropy will support, wherever you have that person from, I think then all the other things can fall into place.
Yeah, I would say that even from the patient perspective, knowing that would give great comfort and help calm the person down who's being suddenly usually introduced into this whole new atmosphere. And I know how important, Cathy, your coordinator is to you. What is your point of view? Who was involved in the decision making at the beginning, and how did you put it together? With part-time help from the different areas of the hospital, or the services offered there, and who was instrumental? Did you have to go to speak to the head of the hospital, or were you able to do this downstream? Yep, you're on mute.
In my case, because my at that time, my division head was the one that basically was provided full support for this effort. So, very similar to what Nancy said, you identify individuals. So we made a list of all the various disciplines that we wanted to be engaged, and we had a point person. And then we had regularly scheduled meetings in the very beginning, just to make sure that if there was any unmet need that we had not identified, we would be able to find an individual that could assist us. And having my first program manager was with us for quite a while. My associate program manager was with us and really passionate about these efforts for the young patient population, and that makes a huge difference too. Having someone that's very dedicated, and as time goes by, obviously, there's still things that still need to be addressed. That it's still not perfect. I think the one thing that's made it a little bit easier in regards to the referral process too is we have this built in automatically into our electronic health record system. So if there's an inquiry for a young adult, there's just a message that goes to a pool, and that goes straight to the basically the associate program manager or the program manager or the nurse navigator, and then that can help guide the patient. I think it's the most important thing is the patient is aware that it is available to them at all times. And actually in all my notes too, I also send them a friendly reminder of what the website is with the list of services. So at least, they can look at their phone and look at their patient portal and remember who to contact or what sources are available to them.
It strikes me that everyone who was involved in the article has a very deep passion for this, and a drive, and it's very hard to say no to any of you. And I think that's something to be recognized, and thankfully, and grateful for that. Not everybody is going to be like you. We do have a lot of passionate people in Canada, of course, whether it's on the surgical or the medical oncology side or otherwise, psychosocial and so forth. But it does take a drive, and it does take patience, and it does take sustaining, keeping with this ask, for a period of time. Was it draining on you guys? Was it something that you sometimes said, well, this is just too hard. I can't do it, or it's not worth it, or was it your passion that got you through it, or is it because everybody else said, "Oh yeah, that's a great idea, let's do it"? Anybody?
Well, if you don't mind, I'll answer first, since unfortunately I have to go to another. I have to finish my other meeting that I'm at. But for me, it's truthfully my passion. I knew it was going to be challenging, but I was already set for the challenge because I felt that this was the most important thing I wanted to be able to create for my career path. It's something I've always wanted, and I felt it was needed for my patient population. So despite all the obstacles, that was my intent. That was my primary objective. And fortunately, it's been a great experience.
So go ahead, Nancy and David. Or David, you're on mute, actually.
Thanks. So I agree with Cathy. I think, we're all clinicians, so we all, have the fortune of being able to see patients on a daily basis. So I think that's what keeps you going. It's no matter what challenge you kind of face, when you then see how it manifests itself on a daily basis in a patient's life, that sort of motivates you and keeps that motivation going, knowing that you can make a difference. Obviously we want to make a difference on a large level, but even on the individual level, that is so powerful that it just, the motivation is there on a daily basis.
Nancy?
Yeah, for sure. It's patient driven. I think all of us, right, have had such a long-standing interest in this problem. Like, I think I wrote a paper on Young-Onset when I was a fellow in colorectal surgery. And so it's been such an anchor to our careers, for my career, that you really want to do something for these patients. And I think it comes back to, the frustrations are always going to be there when a clinician has to deal with an administrator. But, when you go back to clinic and there's a patient in front of you and you learn about their family stories, you're like, okay, I'll fight it again tomorrow. So yeah, it really, I mean, it actually goes back to the patients as
You
well.
know, when we published the paper, we wanted to put more detail about what each of you had to offer in your centers. So I'd love to give you an opportunity to describe, what the services are in each of your centers and what you think is, I would say, the core services that you're offering as well, that really do impact and make a difference in the patient's lives, and in patient outcomes as well. So we'll start with you, Cathy. Tell us, what are the services in your center? What you mentioned that it's not just for colorectal cancer, so we'll come back to that in a minute. I think you started, if I'm not mistaken, initially it was in colorectal, but perhaps I'm wrong.
No,
So
always,
always
always
went
for
for all comers. Tell us, what are those services that you offer that does make a difference in patients' lives and in outcomes?
I suspect it's going to be very similar across all the institutions, but um, you know, number one thing obviously is the discussion regarding fertility. We have fertility family planning. We have an amazing social worker, um, nutrition, psych oncology has been wonderful. We also work directly with the director of the supportive palliative oncology care clinic, body image, sexual function. We have individuals to address that. We have what I absolutely love. We work with survivor fitness. So for those patients that are disease free, it's a free program for training and working with personal trainers, and that's available in our region for like 3 months. And I think that really helps. Also, the psychologically how one feels when going through all your therapy and the recovery afterwards. Um, you know, Obviously multidisciplinary efforts with our surgical oncology, radiation oncology colleagues as well. There's so many different individuals that we work with. I can't list them all. We did try to list them, I think, originally when we wrote the paper, and then it was just too long for all of our programs. But I think it's
I
really
think it's in
important for
the
people to really,
supplemental
yeah.
materials we were able to get it in. Yeah.
Oh, okay, yeah,
Somewhere.
great. Yeah, and having that nurse navigator ideally is the best situation as well. Um, there's so many amazing resources. And honestly, a lot of resources patients are unaware of, but if they ask, they will find that there is something available to them. Even in regards to financial toxicity, there's lots of additional resources that are free actually as well.
Yeah, it is a complex route, and as David mentioned before, having that person who you meet in the first place that helps to guide you through it is fundamentally important. And you mentioned about the exercise part, and that's something actually we're working with Chris Booth to try to change guidelines in terms of for early stage patients in the adjuvant setting to use exercise as a technique, if you will, or treatment, part of the treatment guideline as well. So it's nice to see that there are other uses, both from a psychosocial point of view. I think fatigue is also one of the other issues, that can be addressed with exercise. And I have to take some of my own advice. My wife tells me every day I should practice what I preach. So Nancy.
I apologize, Barry. I have to step away, but thank you
Okay.
so much. It
Okay.
was such my pleasure to join today.
Thank you very much. And we will have some questions coming in, so we'll be sure to let you know if there's any to answer post-conference.
Thank you so
So
much.
thanks. So Nancy, tell us about the services at MD Anderson.
Yeah, so I think of our young onset program as there are other pillars outside of clinical care, right? But focusing on clinical care, basically we have a care coordinator that reaches all the patients who are newly diagnosed patients under age 50, does a needs assessment, connects with them, and then connects them with the battery of support services available. And they're very similar to the list that's already spoken about. I don't think we have anything new. Maybe the only other ones that hadn't been mentioned, maybe we have integrative medicine because some of the young patients are interested in knowing, or they may have already been taking some alternative medications and they want to have a scientific basis about that. Um, Counseling regarding how to talk to your kids. We have a program, the acronym is KIWI, and it's how to inform the kids about your cancer diagnosis and cancer treatment. That's been very well received. But yeah, I mean, I think the services are very similar. But I
I'm
will
curious
say,
about something. One of the things that we talk about, in terms of minimal residual disease or ctDNA is the using of those types of tests for monitoring for treatment going forward or non-treatment going forward. I'm just wondering, are you in your center as part of the early onset clinic? Are you particularly because these are young patients and they have a long, hopefully long life ahead of them? Are you using those types of strategies as well in terms of looking for recurrence as part of the program?
yeah, so I think this is where some of the lines get right. We try not to draw a circle around our program, right? Because they ultimately are a colorectal cancer patient. So everybody, all the other programs that are available to all colorectal cancer patients are obviously available to this subset as well. So in general, we are doing ctDNA monitoring for all colorectal cancer patients. So just as a part of it, right? Like, yes, a young patient would get that as well. But that's not kind of distinctive to the young patients.
Mhm.
Yeah, so I think our program, the acronym is INTERCEPT, and so yeah, we have a prospective use of ctDNA for cancer patients.
And David, so tell us a little bit about the services there. And I'm also curious, is it important to create a community of practice within your institution? We've heard about getting the people together, but is it like a community of practice, or are people just on a list and you can call this service or that service? How does it work? Do you meet together as a multidisciplinary team? How does it work?
Yeah, no, those are great questions. Um, so first of all, in terms of the types of services available, I think they're very similar to what Nancy and Kathy have said. It's sort of there's the core clinical services that always get involved, and then there's the different types of services that are kind of as needed on a by interest basis. But all of them, are important at different times to different people. So. The next question you asked in terms of having sort of the community of practice, and I think that is extremely important. And we definitely you don't want to exclude anyone, right? You want to be as inclusive as possible, so that everybody feels they're part of the center, that everybody feels they have access to it, and we want to make sure that especially at a center like the Cleveland Clinic where we have campuses throughout Ohio, but also in Florida, in London, and Abu Dhabi, right? We want to make sure that everyone who's part of our Cleveland Clinic has access to these services, which gets more complicated the further away you get. But many of the services we have are available virtually or through Zoom visits. So we are able, here in Northeast Ohio, especially to have, from 3 different hospitals. We have 3 hospitals that are NAPRC accredited here in Ohio, right? So centers of excellence for the treatment of rectal cancer that are part of our Young Onset Center, and making sure that everyone feels connected and feels the ability to refer patients for these specialized services. We try to make it easy on everyone, so we made sure that an electronic medical record has an order referral to Young Onset Center. So if there's a patient, if they see a new patient, and then they can refer the patient to the center, and then either a coordinator would just reach out to the patient and ask them sort of where they are and what kind of services they might be interested in, or the provider who places the order can actually in a checkbox select a specific service that we think we should focus on from the get-go. So we want to make it easy. We made sure there's an email, there's a phone number, both for patients but also for providers, because I think one of the critical gaps we are still meeting is that we're not getting enough patients connected with all these amazing services that can be helpful. And be that because providers aren't aware of them, or potentially because patients are being treated at a center that doesn't have access to these services, right? And we talk so much about how we need to raise awareness about this disease, and people need to be aware of it, and we keep harping on the symptoms that alarm symptoms that should bring about the diagnosis, and all that is critically important. But I think that the next part of that message that is also critically important is that it really matters where and what type of care the patient receives. We want to make sure that every patient has access to the best possible care. So, like I think it was Cathy who said before, second opinions are important and an option. Especially in cancer, where you get treated first, especially if that first treatment, is surgical, it makes a big difference. You want to make sure that when you get treated, that you have access to that multidisciplinary team, right? What Nancy said before, sometimes going for surgery first is not the right approach, right? Neoadjuvant treatment, right? There's trials available. You want to make sure that people have access to these trials, that people have access to the best possible care. So, besides being aware of that this is a rising problem, besides being aware of the symptoms, it is critically important for patients and providers to be aware that the type of treatment you receive, that can be variations in that, and that you want to make sure that the treatment you receive is the best possible treatment.
Yeah, you at one point you were talking about some of the providers may not even know about these types of services. So it's not as simple as a build it and they will come. It's really a question of promoting your center as well, so that even within your own network of hospitals, that the providers know that these services are available. I think that this is probably something that you wouldn't intuitively think. You'd probably think, well, we have an early onset center. Of course, people are going to send patients here. We have these resources, but patients don't move from hospital to hospital that easy, as you said. Depends on where you start, whether it's surgery or on the medical oncology side. These are important factors to consider. But I do think that the publicity about what you're doing is extremely important. That's why we're doing what we're doing today, of course, so that people know that these are opportunities that can actually better help to meet the needs of patients and hopefully improve outcomes as well. And Nancy, so where do you see, at MD Anderson in terms of promoting what you do for the early onset? We heard Cathy said that their center isn't specifically colorectal, it's young adults. So how do we differentiate the needs between young adults and and providing treatment for any type of cancer versus colorectal cancer? Is there a distinguishing factors that you think are necessitate having a separate a clinic for early onset colorectal?
So I think there's a lot of room for an early onset cancer program, because when I take a step back and think of cancer, there's the AYA, there's a childhood cancer and AYA cancer program. They're very super successful, but a lot of the focus is on childhood to young adult cancers. So there are different cancer types. And then there's kind of the general cancer programs for typically much older onset, where the median age of onset for colorectal still is in the 60s. So I really think of this young adult cancer population as a gap, because they're dealing with the traditional adult cancers, but they're dealing with it in the age of the traditional AYA age group. So I think neither of those services really fulfill the full needs. And that's why I think an early onset cancer program, there's a space for that. I think many of the psychosocial needs are shared, because ultimately it's a young adult that we're dealing with. And ultimately the challenges are, how do you make sense of cancer in this age? How do you juggle the 10 other things we're already juggling in our 20s, 30s, 40s, and add cancer to it. And how do I navigate the whole health system that I don't know nothing about? So I think some of those needs are shared. There are going to be specific medical needs for sure. So I think there's probably, right, like when it comes to disease-specific needs, there's probably unique things. For us, woundostomy, body image are probably specific needs, but there are going to be a lot of shared needs. So I do think the institutional-wide early onset cancer program aimed for young adults, I think there's a room and a great benefit for that.
Absolutely.
Yeah, go ahead, David.
Sorry, yeah, no, and you know, we recognize the same thing here, and you know, we had a AYA program, and then we started a young onset colorectal cancer program, and you know, leaning on these efforts and building exactly what Nancy said, seeing that there's a lot of shared resources that can be helpful to those. There's overlap between these populations, you know, AYA and you know, young onset. There's a lot of overlap, first of all, in sort of age groups. But there's also overlap in some of the needs, right? The fertility preservation for a young person with colorectal cancer is very similar to an AYA person, you know, with a sarcoma. So, you know, recognizing that there are these shared needs, and instead of having silos, you know, building on those shared needs and sharing resources, especially in times where finances are tough, is critical. So, you know, we are in the process of kind of expanding to our program is called a YPC, meaning Young People with Cancer, which involves our AYA groups, a young onset colorectal cancer group. We have a young onset breast cancer group, and we really, you know, coming together as providers and learning from one another, sharing resources, sharing know-how, sharing experiences, and that is extremely powerful. So we're still kind of in the early phases of it, but we're very excited about our Young People with Cancer program as well.
Yeah, and so similarly, I get approached, right? There's people in that want to do an early onset breast, an early onset lung, and an early onset GI program, and they've kind of approached me to be, hey, you know, having exactly the same conversation we're having today. Where did you start? How did you start? But there's just a lot of synergy, and I think we don't need to be the only ones begging the institution for resources.
Yeah, you know, just I'm going to ask you a couple of quick questions, and then we'll go to our Q&A. I'm wondering what patients appreciate, or what patients tell you they appreciate the most about their program. Is it the fact that they're among other people with colorectal cancer, or is it that they're with younger people, or is it the services? Is there something that stands out in your mind that patients tell you or that they express their appreciation for in particular?
For me, probably what I hear the most is the help in coordination. That they don't have to, right? They don't have to, that it's all here under one roof, or that there's a schedule already populated for them, that there's a dates. Like they don't have to make the individual calls and make the individual appointments and figure out, you know, which dates are the radiation dates and
The
sort of just,
organization.
yeah, take in the organization and the coordination piece out of it.
David?
Yeah, no, I think it's very different from one patient to the other. You know, we'll have patients who write us letters and thanking us for specific aspects of the program. You know, sometimes that's, you know, my surgeon was amazing, you know, really, you know, treated me like a person, listened to me, you know, wasn't just interested in curing my cancer, but was also understood how important my quality of life after cancer is going to be to me, right? And I think that's what we hear more and more, you know, people, especially young people, you know, you don't only want to beat the disease, you want to be able to take advantage of your life after, right? So that's a critical component, and I think focusing on that aspect of treatment, right? It's not just to beat cancer, but it's to come out, you know, as a highly functioning individual with a good quality of life after that is just as important. And having all these services wrap around the patient to make sure that they understand that it's equally important to us, you know, that they're not just a disease we're treating, but a person we're treating. I think that's where it gets recognized, you know, Could it be, it might be a nutrition aspect, a wellness program, an integrative health program. It's very different from one patient to the other, but it's really that philosophy to our patients that's important to them.
Yeah, those little touches do make a difference, and I could tell you that I'll never forget waking up in the ICU with my hepatic surgeon, the late John Daly, holding my hand, and it's in a moment that I never forgotten. Of course, I was never sure if he was just holding my hand to wake me or if he's actually just holding my hand. I'll never know, but I'll never forget at the same time. So, when you have these centers, we want to know, are they working or are they not working? How do you benchmark, your performance indicators, and what are those key performance indicators that you might look to? I'll start with either
Yeah.
of you.
Yeah, I think the easy one is volume, right? That's kind of the first one that becomes apparent. How many patients did we serve? How many lives did we touch? All right, so that's an easy one to follow. Now, obviously the secondary trends, we know that it's an increasing incidence of young onset colorectal cancer. So you would expect the number to go up generally just because the incidence is going up. But the more lives we can affect, the better. And that's kind of the basic one. The second one is then how many of the patients took advantage of, some of the non-core services. Obviously, if somebody has rectal cancer, the bare minimum is that they follow all the guidelines that are set forward, by NCCN, by NAPRC, et cetera, right? But how many of them took advantage of additional services? How many met with a genetic counselor? How many had genetic testing? How many got to meet with a nutritionist? So we're trying to see how many of our patients are taking advantage of some of those additional services that our centers provide. And we're tracking that. At this point, we're still doing it, a little bit on a manual basis, and our coordinators have a lot of work, to track these key performance indicators, but we are getting a little smarter with smart forms that can track it for us in the EMR, than having, Tableau dashboards that measure these things. So we're getting a little smarter and automated in terms of monitoring, because if just having a center and having all these services available, that's not what we're all about. We want to make sure that our patients use them, right?
Nancy.
Yeah, so I think the performance indicators are difficult. As David just talked about, right? There are performance indicators that relate to the functioning of the center and the operations. And they're on some level easier, right? Whether it's the patient numbers, we also track kind of access is a big problem for us. So we tracked the interval between the patient making a phone call to when they actually got an appointment to be seen. And so those things, for us, we define those metrics based on the points of improvement that we want to focus on. And so then, yes, the proportion of services utilized is one of the outcomes that we track. But I think the more difficult piece comes in, what are the patient-facing outcomes that we really need to measure? So right, I mean, what are the patients really, do they perceive a better level of care? Is their experience better? And does it translate to outcomes? I think those things are much, much harder to define and measure. And we are struggling with that. And so, I think, hopefully this community can come up with what to do with that. And our patient advocates hopefully can help with that as well.
I think in the large academic centers, the research component is going to play a bigger role. How do you see the future of your clinics and the future of what we're doing in early onset of colorectal cancer programs?
From a research standpoint, I think we touched on some of those things, but to just tag on to what Nancy said in terms of figuring out what's important for outcomes and figuring out what's important to our patients, having better patient-reported outcomes, to see what's important to patients and to collect these data, regularly, having validated instruments that tell us, what is important in this specific population. We have validated instruments for certain subset of symptoms that we're looking, be it sexual health, reproductive health, looking at bowel function. We have lots of different instruments and scores that we can ask about. But having sort of more of a comprehensive approach of, for this patient population, what are patient-reported outcomes that are important and that are actually that correlate with outcomes and that are meaningful, right? And I think that's something we're all very interested in. It is difficult to collect these data because our patients already get a lot of demands on their time with surveys and questions and so we want to make sure we use their time valuably, right? Like we don't want to give them thousands of questions and then maybe have one paper that gets written about it and never again gets spoken about again, right? So we want to make sure that we do the right studies to figure out what's important, and then something that we then socialize and make sure that we have momentum and that can get done in multiple centers, for us to come together like we did for this paper that's in the chat, where we can then pool our resources, pool our know-how, pool our patients, really to figure out what is important in terms of outcomes and patient-reported measures.
I'm going to turn to the Q&A for a few questions here. So in one of the questions, I'm going to put two of these together. And the first one was, is there something that you, in retrospect, would have done differently? Were there lessons learned? And secondly, what advice would you give to programs in smaller and non-academic centers? So we'll start with you, Nancy. So is there something you would have done differently? And is there an advice for non-academic
There is
centers?
something I would have done differently. So I think I would have just gotten started. I think I wouldn't have waited for a comprehensive mapped out program. I think you can start small and just get started, right? It's like applying for a grant. They fund people who's already done something.
So you
I would
subscribe to the Nike theory, just do it.
just do it. So I think if you have a group of 2 or 3 people that's interested, just name it a program and start doing it. And then you can always perfect it, right? You can always add people to it. You can always add components to it, and you can always formalize it. But I think I know in the process of asking for institutional help, they were almost like, well, what, like, right? It's a better ask if you already go in saying, hey, we've already done this with absolutely zero resource. Now can we have some?
And of course, you both work in large centers, NCCN centers, but of course, not every center is like that, particularly in the community. So what do we tell those clinicians in smaller centers who are interested in having a clinic of this nature or the services and see early onset patients?
I would just start a registry of young patients.
In
And
the
then maybe
community.
partner with, if there is a major center or that has an established program, partner with them and or partner with community resources for the different services.
Mm-hmm. So one of the things that comes to my mind, which we've kind of utilized in clinical trials by way of example, is by putting physicians together in a community of practice, even though they're, in the case that I'm thinking about it, throughout the province of Quebec. So large territory, many different centers, but creating that community of practice where they can meet and discuss and provide at least information for resources to other physicians so that they can give that to their patients. David, in Cleveland Clinic with so many different campuses and international aspects, how do you manage that? And is it like giving information to a smaller academic center? Are there differences?
Yeah, no, yeah, we have, largest hospitals that are affiliated with us. We have smaller hospitals, and there's less resources available at different campuses, right? Different campuses might have different resources, less resources. And I think we need to realize that the world is becoming smaller thanks to technology, and there's more access to services, all around the globe, just because we're more connected. And we have now, global tumor boards where we meet with different campuses from around the world where people can discuss complicated patients. We had a meeting just last week with our Abu Dhabi campus, and we were able to talk about patients and how would we do things in Cleveland, how would we do things there. And usually the services, can be shared, like I said, even across long distances, especially if the main service is just, how should we do this? What else should we be doing in this patient? Now, there are certain, expert services or techniques or technology that is not available elsewhere. But the first step is to recognize, would this patient even benefit from such a service? Let's say we're talking about intraoperative radiotherapy. Definitely not something that's available at all campuses of the Cleveland Clinic. But most patients don't need it, right? But having then for that specific patient that needs such a service, to know that this, or, like Barry, you yourself, you said you had to travel to get the hepatic artery infusion pump, right? Knowing which patient would potentially benefit from a service and then identify which patient might actually have to travel, that is important. Most patients won't need to travel, but having that discussion available so that we know which patient will get everything they need exactly where they are. That's the goal. But also recognizing those rare individuals that should be able to travel.
So it does start with patient identification and determination who will benefit from which resources. But you did touch something that I just want to close with today, and that is the use of artificial intelligence and networking of information. So, many physicians today are using, whether it's ChatGPT or Open Evidence or some of the other programs out there. I'm just wondering, is there the use of AI and early onset clinics? Does this help you to put together your identification of what resources are best for patients? How do you use it, and do you use it to it's sort of to bring together those different components in a particular case? Well, I guess the simple question is, how do you use AI?
Yeah, I must say we're not using AI in that sense quite yet. We are, like I said, we are working on automating things, and especially that patient identification is critical. So we are able to use our electronic medical record for any patient under the age of 50 who comes in with a diagnosis, with any cancer diagnosis now that the cancer was diagnosed on the age of 50, that patient gets added automatically to a dashboard, which then gets reviewed by disease-specific coordinators, and they will then identify the patient and reach out to the patient. So it's not quite artificial intelligence yet. There's still a lot of, man and woman power, behind it to make sure things are happening. But automation is critical so that we really identify every single patient, so that every single patient that potentially could benefit from specialized services will have access to them. But yeah, I think the future for artificial intelligence is there. I mean, it's being used in so many areas already. And we at the Cleveland Clinic strongly believe in using it, and it is being used operationally in many different aspects. In the young onset space, we haven't sort of handed over the reins to AI quite yet, but I think we'll get there.
Last word to you, Nancy.
Yeah, similarly, right? Totally love the AI incorporating it, but not actually using it. The two areas that I think will be super helpful is there's a lot of kind of coordination work, right? Like someone wants to make an appointment, someone wants to change the appointment, that sort of thing, right? Like having an AI interface, I think will be really helpful for the young patients. And then second is, one of my questions is how do you make this scalable? Right? How do you make it sustainable and scalable? And I think AI will play a role in there, whether it's not substituting, but supplementing the work of the coordinator or supplementing the needs assessment piece. But some of those AI, I can see those as the main areas where AI would be super helpful.
I do think that in the area of coordination, and certainly you will use it perhaps to remind some of those people who are less informed. Obviously, not everybody can be as informed as someone who does it every day as to the opportunities and benefits of early onset clinics. So with that, I want to thank both of you very much, and of course, Cathy as well, Cathy, Dr. Eng as well, as our other co-authors. Remind everybody that that blueprint article, which is in the chat, is available for review. And if I may, the contact information is in the article for all of the co-authors for anybody who wants to reach out. I would encourage all physicians, particularly in Canada or in the United States or anywhere who is listening to this, to feel free to reach out, because that is the I would say the first steps. You know, if you have an interest in early onset colorectal cancer, reach out to your colleagues and patients and patient groups, because if you don't, nothing will happen. And I have to say, doing litigation for a part of my life as a lawyer, there was one sort of theory that we had, and that is, if you do nothing, nothing happens. So if you want something to happen, do something. Do feel free to reach out. That's why we did this webinar today, and why we're so proud to work with all of the co-authors and our guest speakers today. So thank you once again, and I look forward to speaking in the near future.
Thank you so much, Barry, for all the work you do.
Thank you.
Thank you.
Thank you.
Right.